In fact, the outer endothelial layer of the juxtacanalicular meshwork comprises the inner wall of the Schlemm's canal. So this part of the trabecular meshwork mainly offers normal resistance to aqueous outflow. So if any deposits or debris would be there in this meshwork, because of that also outflow won't occur. I'll show you the picture. Again, one more picture I'll show you, then you can understand it very easily. So now coming to the Schlemm's canal. So for this, just remember those in the diagram where the Schlemm's canal is located. So everyone could locate where the Schlemm's canal is, right? Schlemm's canal, intrascleral plexus, trabecular meshwork. So if here you could locate that, it would be easy for you. You could locate, right, where the Schlemm's canal is present, aqueous vein and all. Okay, good. Next thing. So about Schlemm's canal, it's an endothelial lined oval channel present circumferentially in the scleral sulcus. So the endothelial cells of its inner wall are irregular, spindle shaped and contain giant vacuoles. So the outer wall of the canal is lined by smooth flat cells and contains the openings of collector channel. So just remember it's like an oval channel which is present, and next the cell walls are like irregular, and other than that it helps for the openings into the collector channels. Like from the Schlemm's canal it could go through the veins, aqueous veins and all, and next it could get collected in the collector channels, and finally it goes out through the episcleral vein. And collector channels, these are also called as intrascleral aqueous vessels. If you remember in the previous picture, I have shown you like the intrascleral plexus, right? So those all come under the collector channels. So intrascleral aqueous vessels are about 25 to 35 number and leave the Schlemm's canal at oblique angles to terminate in the episcleral veins in a laminated fashion. And these intrascleral aqueous vessels again could be divided into two systems. So the larger vessels are called as aqueous veins, run a short intrascleral course and terminate directly into the episcleral veins, which is called as direct system. And many other small collector channels form an intrascleral plexus before eventually going into the episcleral veins, which is called as indirect system. So what are the types of the collector channels? See, from the Schlemm's canal, these collector channels would be there. And what are the types in that? Collector channel types I'm asking. Direct and indirect. So which one is called as direct and which one is called as indirect? So now tell me which one is called as direct and which one is called as indirect. Okay, direct flow into the episclera is direct, right? But it's like through the aqueous veins, not like directly aqueous veins. If it enters into the episcleral vein, it's direct. Or otherwise, if intrascleral plexus forms, and later if it drains into the episcleral vein, we call it as indirect. So again, just to make sure, I'm showing you the diagram. So one, it shows the direct system of collector channels, and the second one, it shows with the intrascleral plexus, which is called as indirect type of collector channels. So these are like the two types. And how many collector channels would be there? forgot already. I'll show you 25 to 35 number roughly. And now coming to the drainage of 25 to 35. So now coming to the drainage of aqueous humor. So it flows from the posterior chamber to the anterior chamber through the pupil. It means slight physiological resistance. And from there it is drained out by two routes, which is conventional outflow, the trabecular outflow. It forms the main outlet for aqueous from the anterior chamber. So about 90%. Few books write it as 70 to 80% and 90%, but most of it drains through the trabecular outflow. And free flow of aqueous occurs from the trabecular meshwork up to inner wall of the Schlemm's canal, which appears to provide some resistance to the outflow. Just remember, the inner wall of Schlemm's canal offers a mild resistance to the outflow. And mechanism of transport, like across, like how the aqueous transport occurs through the wall of the Schlemm's canal. If possible, like I'll put one more picture and then I'll send you through backpacks and all. So you know about backpacks, right? In the imparters classes, in backpacks you can see, you can get your PPTs. Yes or no? Okay, fine then. So I'll add that and send you if possible. And here just remember like how the transport occurs through the Schlemm's canal. So it's called as vacuolation theory, which is the most accepted view. So if the diagram is present, it will be very easier for you, and later if possible I'll share that also. So according to it, transcellular spaces exist in the endothelial cells, forming the inner wall of the Schlemm's canal. These open as a system of vacuoles and pores, primarily in response to pressure, and transport the aqueous from the juxtacanalicular connective tissue to the Schlemm's canal. So juxtacanalicular, as I told you before, it would be near or adjacent to the Schlemm's canal. So from the Schlemm's canal, the aqueous would be transported via 25 to 35 external collector channel into the episcleral veins by direct or otherwise indirect systems. Now I hope you all understood about direct and indirect system. And next, a pressure gradient between intraocular pressure and intrascleral venous pressure is responsible for unidirectional flow of aqueous. About this I'll tell you it. See, you know about osmosis, right? When higher molecules and all, at higher concentration it diffuses from higher concentration to lower concentration. Yes or no? About osmosis you know, right? Like active flow, passive flow. Okay, good. So in the same manner, see example I'll tell you. Intraocular pressure for a patient is about 15 millimeters of mercury, and whereas intrascleral venous pressure is lesser than that. So how the outflow occurs generally? Understood my question? How to tell you? Wait. Intraocular pressure, like within the eye, the pressure is about 20 millimeters of mercury, and intrascleral venous pressure, it's about 10 millimeters of mercury. So how outflow occurs? Like aqueous flow would be inwards or otherwise outwards. Okay, very good. That's why I asked you, ma. So that's why whenever the pressure gradient is present, only then aqueous flow will occur. So that's why they have mentioned it here. So whenever pressure gradient develops between intraocular pressure and intrascleral venous pressure, because of that pressure difference, unidirectional flow of aqueous occurs. So based upon the pressure gradient, if outside pressure is very high, aqueous outflow won't occur. So next, coming to uveoscleral or unconventional outflow. Roughly it comprises about 10% of the total aqueous outflow. So aqueous passes across the ciliary body. See, from the name itself you can answer this, so don't worry about it. In the name it's there uvea, right? So in uvea, it comprises of about ciliary body and choroid also. So you can think like aqueous passes across ciliary body into the suprachoroidal space. And next, it is drained by the venous circulation in the ciliary body, choroid and sclera. So it passes through the ciliary body, next supraparietal space, and next drained by the venous circulation. Again through the veins which are present within the ciliary body, choroid and sclera. All these terms are there in the name itself. In uvea, it can comprised of ciliary body, choroid, you know, right? So leave about the iris. So ciliary body, choroid, and next through the sclera. So next about the drainage, I'll show you one flowchart also. Yeah, here I'll show you. So now tell me how the maintenance of intraocular pressure occurs. It's because of the aqueous humor. Yes or no? So intraocular pressure maintenance and all, it occurs because of aqueous humor. All got bored or like able to understand? Okay, understood. Okay, fine. Now, speaking about intraocular pressure, it refers to the pressure exerted by the intraocular fluids on the pores of the eyeball. So the normal intraocular pressure, again this is very important. Normal intraocular pressure, it's about 10 to 21 millimeters of mercury. The main value like 16 plus or minus 2.5 millimeters of mercury. So whenever any examiner asks you, you shouldn't mention like mmHg and all. You should say millimeters of mercury. And next thing, the normal level of IOP. IOP is nothing but intraocular pressure. It's essentially maintained by a dynamic equilibrium between formation and outflow of the aqueous humor. So if formation is very high, see saying some tumor is there in the ciliary body, then formation would be very high and outflow won't occur. So because of, outflow won't occur till that extent. Because of that also eye damage occurs. So every time there should be an equilibrium between the intake and next the outflow also. So the various factors which influence this intraocular pressure, roughly I'll give you a vague idea about that. So how this intraocular pressure can vary. So now tell me first the normal intraocular pressure value. So what's the normal intraocular pressure value? Very good, 10 to 12 millimeters of mercury. So now first I'll show you the chart. Chart, just remember that, because if you simply draw this chart also, each and every person can understand that. See, from the ciliary process, aqueous is coming to the posterior chamber, and from the pupil it goes to the anterior chamber. So now tell me, in the posterior chamber, how much aqueous composition would be there? See, for anterior chamber I told you 0.25 ml, right? So now I'll check who remembered that in the posterior chamber. Okay, good. Somewhat guessed rightly. Very good, ma. It's like 0.06 ml, ma. Yes, very good. 0.06 ml. So next, in the anterior chamber, the outflow occurs through the trabecular meshwork, and next Schlemm's canal, collector channels, which comes under conventional outflow, and the other thing would be ciliary body, supraparietal space, and through the veins. Venous circulation of ciliary body, choroid and sclera comes under unconventional outflow, about 10%. So all the factors which help for this aqueous formation, or which help for which reduce the aqueous and increase the aqueous, I'll roughly tell you about that. So rate of aqueous formation influence the IOP levels. Say think aqueous rate and all roughly, like how the aqueous production would be, I'll tell you. The production rate is normally 2.3 microliters per minute. So whenever the production value keeps on increasing, then also the outflow drainage and all would be impaired. So all this, how much aqueous is formed, based upon that intraocular pressure would be. So we think if some 2.3 microliters per minute, I told you, right? If 5 microliters per minute aqueous has been produced, then intraocular pressure would be very high. See, for normal it is 10 to 21 millimeters of mercury. So in such patients, it would be about 30 millimeters of mercury. See, in the body, how hypertension affects our body. Whenever high blood pressure affects our body, in the same manner, high intraocular pressure also affects our eyes. So, to understand, I'm telling you in that manner about hypertension and about intraocular pressure and correlating that. And next, so how the rate of aqueous formation, it influences the IOP levels, and aqueous formation in turn depends upon many factors like such as permeability of the ciliary capillaries, and next about the osmotic pressure of the blood. Osmotic pressure of the blood is nothing but, before I told you, right, intrascleral venous pressures and all. So based upon that also outflow and all depends upon. And next thing, resistance to aqueous outflow. See, at this lens canal or at this trabeculum, if any debris, whatever I told you, metabolites or any matter or inflammatory cells deposits occur, because of that also aqueous outflow will be impaired. Like from clinical point of view, this is the most important factor, and most of the resistance to aqueous outflow occurs at the level of trabecular mesh. And increased episcleral venous pressure may rise in IOP. So there should be a difference between the pressure gradient. Intraocular pressure should be high and episcleral venous pressure should be less. Because of the pressure gradient, aqueous will go out. So whenever episcleral venous pressure is high, outflow can't occur. So the Valsalva maneuver causes temporary increase in episcleral venous pressure and rise in IOP. Valsalva maneuver is like closing the nostrils and then blowing the air and all. Because of that also pressure within the eye increases. And one more thing, dilatation of pupil in patients with narrow anterior chamber angle may cause rise in IOP owing to relative obstruction of the drainage by the iris. See, think for a person only 10 degrees of angle width is present. Normally think 30 to 40 degrees should be there, but for that patient only 10 degrees of angle of anterior chamber is present. In that patient, you instill drops and dilated the pupil. Because of that, angle width would be much more narrow. See, for 10 degrees, it goes to 0 degrees after dilatation. So because of that, complete outflow would be impaired. And later on, sudden rise in intraocular pressure occurs, and later on, glaucoma problems and all could arise. Understood? Okay. So obstruction occurs through the iris or through the root of the iris. So now coming to general factors and all, like hereditary. See, for your parents, if intraocular pressure is high, in the same manner, like for the children, whoever inheritance is there, for them also IOP, intraocular pressure would be influenced. And age, like roughly mean IOP, average IOP increases after the age of 40 years, possibly due to reduced facility of aqueous outflow. See, excessive thickening or sclerosis of the Schlemm's canal and trabecular meshwork occurs. Because of that, outflow would be impaired after the age of 40 years, I'm telling you. And next, related to sex, IOP is equal mostly between the sexes, between both males and females at around ages of about 20 to 40 years. In older age groups, increase in mean IOP with age will occur, and it would be more especially in females. And moreover, they mentioned like for females, this suffering or this IOP pressure or fluctuations would be more. And coming to diurnal variation of IOP. What does diurnal variation mean roughly? Can anyone tell me, ma? Diurnal variation means? Just the term I'm asking you, diurnal variation. Diurnal variation, you guessed correctly, ma. But that comes under diuresis. Water flow and all, like it comes under diuresis. But here, diurnal variation is about how it varies within the day. Like within the day, how it changes and all. See, nocturnal, diurnal, you would have heard about it, right? In the same manner. So here, it would be like there would be a tendency of higher IOP in the morning and lower in the evening. This is related to diurnal variation in the level of plasma cortisol. So normally the eye should be having a smaller fluctuation, like less than 5 millimeters of mercury. So whenever it is more than 8 millimeters of mercury, then we can suspect it could be a case of glaucoma. So think in the morning the intraocular pressure could be high, whereas in the evening intraocular pressure would be less. This is because in the morning itself plasma cortisol would be produced. Plasma cortisol and all, it's nothing but like a steroid hormone which increases the intraocular pressure. So physiologically in our body it would be produced. So in a normal patient, there would be a change less than 5 millimeters of mercury. So whenever the change compared with the day and evening, if it's more than 8 millimeters of mercury, then you can suspect a case of glaucoma, like a case where the eye could get damaged. So what is the normal diurnal variation value of IOP? Yeah, like less than 5 millimeters of mercury. Very good. And postural variation is nothing but IOP increases when changing from sitting to the supine position. Supine position is nothing but, like to say, the face would be seeing the roof. And if the face would be seeing the floor, what we call it as, I mean, what's that position called as? If face is watching the roof, I told you it's supine position, and if face is watching the floor, then that position is called as about the sleeping positions. These two are, so that's why I'm asking you. Just tell me if you know or not, otherwise I'll tell you. Okay, supine
Class
position, I told you right,
students.
face towards the roof and face towards the floor and all while sleeping in that manner, that position is called as prone position. Supine and prone position. So next, blood pressure. As such, it doesn't have any long-term effect on IOP. However, prevalence of glaucoma is marginally more in hypertensive than the normotensive. See, whenever the body blood pressure is also high, there is an increased chance for that patient to have intraocular pressure also high. Like risk would be more in such patients. And next thing, coming to osmotic pressure of blood, an increase in plasma osmolarity as it occurs after taking like IV mannitol or oral glycerol or in patients with uremia. Uremia is nothing but, remember, when in the body like high uric acid concentration is present, which would be associated with a fall in IOP. While a reduction in the plasma osmolarity as it occurs with water drinking provocative tests. At present, remember, water drinking provocative tests are nothing but like taking like 2 or 3 liters of water at an instant. So is associated with a rise in IOP. And next thing, general anesthetics and many other drugs are also influence IOP. Alcohol lowers IOP, but it doesn't mean like they need to take alcohol because there are many other side effects other than this. And tobacco, smoking, caffeine, and steroids may also cause rise in IOP. In addition, there are many anti-glaucoma drugs which lower IOP. And if, again, related to the glaucoma and the drugs which we'll give, we'll discuss about it later. But at present, just remember, again, smoking, caffeine, steroids, and all also increases the IOP. So understood till here? So about angle of anterior chamber, structures present in that, Schafer's grading, outflow, and the normal physiology. Yeah, and what's the theory called as? So the Schlem's canal, like how it outflockers, aqueous humor, and all. The theory name I told you, right? Vaculation theory. Very good, very good. And how it changes, like based upon the age and all. It all comes under like the normal anatomy and physiology of aqueous, like how it changes over. So can I continue? Okay. And next thing, just tell me which one is sixth now. What's the name of that? Sixth name I'm asking, ma. Sixth now. Conventional, unconventional, and all. So we'll discuss about sixth now. So just tell me sixth nerve supplies which muscle. So then I'll tell you like the origin and all about the sixth nerve. With this topic, like a few slides are there. With this topic, we'll close it. So don't worry about sixth nerve. Just tell me like which muscle it supplies. Sure, superior oblique. Lateral rectus, ma, very good. Sixth nerve supplies lateral rectus. So again, just I'm repeating that. If you remember, I told you all extraocular muscles supplied by oculomotor nerve except SO4, LR6. SO stands for superior oblique, and fourth nerve is okay. You need to answer which one is fourth nerve and which is second nerve. Then I'll start this session and we can close it soon. Okay, good. Trochlear nerve and second nerve. Fourth is trochlea. That's good. No, ma. Third nerve is oculomotor. If I'm correct, it's oculomotor. I am asking second nerve. Okay, good. Yeah, optic nerve. And next, now starting about the anatomy of abducent nerve. So, see, all these terms and all would be like a bit difficult to remember, but you should know the origin and all because, see, again, if any tumors are present near to the structure and all, you should know like which nerve could get damaged and which nerve is present near to that part of the brain. And next, coming to anatomy, so you all can see the slides. Okay. So anatomy, it's like a small, entirely motor nerve. Motor nerve, which means it only supplies the muscle. That's all, and no sensory sensations are present. See, for trigeminal nerve, skin sensation or corneal sensations will be present, right? That won't be there in this case. So entirely motor nerve supplying the lateral rectus. And other than that, functional components which include somatic afferents for lateral movements of the eye. You know, right? Afferents would be taken like to the nucleus or to the nerve, and efferents from that. So it helps for the lateral movement of eye because lateral rectus it supplies it, and lateral rectus it helps for abduction of eye. And other than that, it includes general somatic afferent proprioceptive impulses from the lateral rectus muscle. So, which means again, proprioceptive impulses is nothing but pain impulse or any stimulus impulse. So, if anyone touches that muscle and all, the stimulus would be passed again through this sixth nerve and ultimately reach the mesencephalon. So, you all know, right, about the brain parts and all, prosencephalon, mesencephalon, like midbrain and all, you know or not? Cerebrum, cerebellum. Okay. So now coming to the nucleus. situated in the lower part of the pons beneath the floor of the fourth ventricle. And next, fasciculus of seventh nerve also curves around. Like seventh nerve also curves around the abducens nucleus. So what is seventh nerve? Because whenever they use those terms or like they use those parts of the yes, good. So you need to answer immediately. Yeah, patient nerve. There would be two types of multipolar cells, and large fibers of abducens nerves will be present, and small fibers would rely upon the third nucleus, which means along the oculomotor nerve nucleus, and form para abducens nucleus. See, large fibers would be of abducens nerve, and small fibers they rely upon the third nerve nucleus, and they form para-abducens nucleus. So remember, there is one more term called as para-abducens nucleus also. And sixth nerve nucleus in line with nuclei of third, fourth nerves above, which includes, along with that, near to the pons, the structures which you would be seeing would include nucleus of hypoglossal nerve also. So now tell me, hypoglossal nerve forms which part of the cranial nerve? Hypoglossal nerve. Okay, then which one is 12th now then? Okay, then by the end of the class, you will be answering about which one is 11th and which one is 12th and how many cranial nerves are present. Every one of you. Is that okay? 11th nerve, 12th nerve, and how many cranial nerves are present. Is that okay? Okay, good. And next, coming to the connections of the nucleus, like how this abducens nucleus gets connected. See, remember, cerebral cortex, it would be like a motor cortex, and for visual cortex, it would be connected through superior folliculus or through the tectobulbar tract. Sorry, I'll just correct it. It's like a tectobulbar tract, like tectum of midbrain, we say. And frontal cortex, and nuclei of third, fourth, and eighth cranial nerve form medial longitudinal fasciculus. See, if you books write it as MLF and all, so don't get confused with those terms and all. It's called as medial longitudinal fasciculus. MLF stands for. And pretectal nucleus, it forms the tectobulbar tract. And PPRF, can anyone answer? Because all these are like the basics in general when we used to read about the anatomy of brain and all, it comes under. If people from BIPC can answer this, I guess. PPRF.
ఏంటి 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 లే వైర్లన్నీ కనెక్ట్ అయ్యి ఉన్నాయి కదా.
Okay, no. Okay, then I'll tell you. Paramedian pontine reticular formation. So don't forget PPRF, paramedian pontine reticular formation. It forms a medial longitudinal bundle. All these terms are important. Like whenever we discuss about again related to the ocular diseases and all, there we mention medial longitudinal fasciculus could get damaged, MLF, or otherwise PPRF will be damaged, and along with that, abducens nucleus, para-abducens nucleus can also get damaged. So all these terms are important then. And at the cerebellum, the nuclei which are present would be vestibular nuclei. Because you know, right, cerebellum is used, generally, its main function is like maintaining coordination of movement. Coordination of movements and all in the same manner, like related to the eye also, it maintains. Sorry, related to the ear. So that's why it's called as vestibular nuclei. And next, course of the abducens nucleus, we divide it into four types, like starting from the fascicular, basilar, intracavernous, and intraorbital. We'll discuss here. So remember, those are the four parts. Like how the abjacent nucleus will be continuing. Abjacent nerve. So efferent fibers start from the nucleus. Nucleus is nothing but adjacent nucleus. Efferent fibers will start from there and traverse the medial lemniscus and the pyramidal tract, and next emerge by 7 to 8 rootlets at pontomedullary junction, and rootlets join and form the nerve. See, ponta, medulla and all, don't get confused. I'll tell you one thing, wait. Cerebrum, and behind that, beneath that you'll be seeing cerebellum. And other than that, we call it like forebrain, midbrain, and hindbrain, right? In the same manner, there is one more term called as brain stem. Brain stem means which includes midbrain, pons, and medulla oblongata. So, whenever we include both pons and medulla, we call it as pontomedullary part. Or otherwise, in between pons and medulla, we call it as pontomedullary junction. So all this indicate about how the nucleus will, where that nucleus would be and how the fibers would be formed and extended further. So basilar part, and now it leaves the brainstem. So think it's like at the base of the cerebrum and all. So basilar part, it leaves the brainstem at pontomedullary junction and enters prepontine basilar system. So it passes upwards towards the base of the skull, crossed by anterior inferior cerebellar artery. So have you heard anytime about circle of Willis and all? These arteries and all form circle of Willis around the brain. Heard those terms or not? In these all, like roughly you need to remember, like it would be present at the pons and all. This all you need to remember, ma. But just I'm asking you, like circle of Willis, have anyone heard? It's okay, no problem. And next, from that basilar part, it fires a over the tip of the petrous bone, passing through the inferior petrosal sinus and Dorella canal to enter into the cavernous sinus. So for this, you just remember, like around the base of the skull, this part is present, adjacent nerve is present, and after that, clinoids are all are nothing but like the projection from the brain, which you could see, like bony projections, you could call like, which would be seen at the base of the brain. And after that, it passes through the Dorella canal. This is most important because many of the examiners will ask you like which uh, which nerve or like which cranial nerve would pass through the Dorella canal to enter into the cavernous sinus. And about cavernous sinus anatomy and all, we'll discuss soon. So next, coming to the intracavernous part. See, next it passes through the cavernous sinus. So that's why we call it as intracavernous part. So it lies between the third and fourth nerves and the first division of fifth nerve. Fifth nerve is trigeminal. And now tell me, what is the first division of trigeminal nerve?
Class.
First part of the trigeminal nerve. No one. First part of the trigeminal nerve is not adjacent, huh? Like still 3 or 4 slides are there. Is that okay to continue?
No, no.
Yeah, very good. Ophthalmic. So I could continue, right? Like hardly 3 or 4 slides are left over. Okay, fine. So remember, so ophthalmic nerve is the first part of the trigeminal nerve, and others are maxillary and mandibular. I told you, right? 3 parts of the trigeminal nerve. So even during the superior orbital fissure, which structures pass through, there also we discussed about this. Not about the trigeminal nerve, like about third nerve, sixth nerve, like nasociliary nerve and all we discussed, right? So all this come under that. And next thing, see intracavernous part of the sixth nerve, it's more prone to get damaged because it is most medially located and closely related to the internal carotid artery. Even internal carotid artery also passes through the cavernous sinus. So whenever intracavernous sixth nerve palsy occurs, it would be accompanied by postganglionic Horner syndrome, otherwise known as Parkinson's sign, because sixth nerve would be joined by sympathetic branches from the paracarotid plexus. So now just remember, see example, only if sixth nerve palsy occurred, patient abduction would be impaired. And along with that, if any other symptoms are present, like think drooping of eyelids or otherwise pupil became very small. So other findings are also present. Based upon that, you can think at which structure this nerve palsy has occurred. You know, right? It started from the pons and from the pontomedullary junction to the base of the skull. Next, passed through the cavernous sinus and all that. So, if the damage occurred at near to the cavernous sinus, along with that, sympathetic nerves or sympathetic plexus from the carotid artery near to the carotid artery could also get damaged. So that's why, along with lateral rectus muscle palsy, you could see other findings also. So based upon the findings also, you could say like at which structure, at which part of the sixth nerve got damaged. So now coming to the intraorbital part. For this, everyone know intraorbital is nothing but like within the orbit. So it enters the orbit through the superior orbital fissure middle part. If you remember, I have made everyone, to speak about which structures pass to the superior part, inferior part, and middle part, if you remember. So in inferior part, you'll be seeing inferior ophthalmic vein, superiorly superior ophthalmic vein. In the same manner, this nerve, sixth nerve, would pass through the middle part of the superior orbital fissure. Like when you read that, you'll understand, don't worry. So it lies introlateral to the oculomotor and nasociliary nerves. So if you see the diagram later, then you'll understand. So in the middle part of the superior orbital fissure, the other structures which pass through that are nasociliary nerves and oculomotor nerves. So it enters the ocular surface of the lateral rectus muscle. After passing through the orbit and superior orbital fissure, it enters near to the lateral rectus muscle. So everyone understood till here? Okay, very good. So now tell me how many cranial nerves are present in that, with that, those answers will close the session. Because all this come under the basics, and if you don't answer the basics, even the examiner won't ask you further. 11 cranial nerves, I think it's 12 cranial nerves, ma. Yeah, 12 cranial nerves, and the 12th one would be hypoglossal nerve. And can anyone tell me which one is 11th nerve? Because here we discussed about hypoglossal nerve, and that's why I asked you which cranial nerve is that. Now I mentioned it's 12 cranial nerve. So now tell me which one we call it as 11th cranial nerve. 11th cranial nerve name, I'm asking. Very good. And a few books mention it as spinal accessory nerve also. Spinal accessory nerve or spinal nerve, it stands the same. Okay. Right. So before closing it, like everyone are like safe, right? Everyone are healthy, no problems, right?
దేవుడు తీసిండు మళ్ళా వేడి ఎంత వస్తుందిరా
Okay, so don't step away from your home. Be safe and hope to see you all soon. And all the best for your internal exams also. Take care, everyone. See you in the next class, ma. I'll just put a session and all, and I'll let you know. Or otherwise, I'll inform Narendra. And I think you'll get mail also.